live now, ma'am.
Thank you. Good evening, one and all. We are happy to welcome all the speakers, the delegates, Dr. Vijaya ma'am, on behalf of OBGYN PULSE, the midweek webinar series. In this episode 2, we are going to have two excellent speakers who are going to talk to us on session 1, high pressures, managing hypertension in pregnancy, and session 2, new beginnings, where we are navigating ART loss. So let me go ahead introducing the convener of the OBGYN Pulse, the webinar series, Dr. Vijaya ma'am. Can I have the next slide, please, Sahiti? So, Madam is known to everybody as the president of OXY in 2024-25. She's been the former director of IOG Madras Medical College from 2019 to 22, former director of Institute of Social Obstetrics and Gynecology from 2013 to 2019. She has been the member of FOXY and OXY Medical Education Committee. With a rich teaching experience of about 3 decades, she has been a faculty of most of the undergraduate and the postgraduate revision courses. She's been the state level master trainer too, and national master trainer too in safe deliveries. And she's been the FOXY master trainer in HPV awareness. She has also played a very important role in getting the Lakshya certification. And she has conducted previously Aksharam webinar series, an educational series, along with the FOXY members. And the convener of Aksharam webinar series, and now the OBGYN Pulse webinar series with 3 decades of teaching faculty. She's now the candidate for chairperson for FOXY Medical Education Committee 2025 too. Ma'am, I welcome you to proceed with the webinar, ma'am.
Thank you. And can I have the slide of Madhu?
Ma'am, we'll go ahead with the lighting of Kuttuvelakku, ma'am. That is actually taken off.
Shall we start with the lighting of Kuttuvelakku?
Yes, ma'am.
Can I have the slide of Madhu, please, Sakti? Sagiti.
Ma'am, there is some technical issue because of which it is not there, ma'am.
Okay.
So I will just introduce myself.
Yeah.
Probably.
No. Madhu is the co-convener of this mid-week Pulse webinar series. And she was my student during her graduation days, and now she is in NOVA IVF and a very leading consultant, and she is almost there in all of the debates. And whatever you want to fight, you can call Madhu. That much of knowledge she has in IVF. And Sonia ma'am, when I said someone in IVF, she suggested you immediately. So nice of her. And I select OG teacher and she will select IVF teacher. That is how we go hand in hand. Welcome, Madhu. You are asset to OG people, and welcome you, Madhu.
And an asset to NOVA as well. She is an asset to NOVA as well.
Thank you, ma'am. Thank you so much for those words. Hearing from you both, that really, thank you so much, ma'am.
Yeah. Can I have a sir's slide, please, CV? Yeah. Dr. Ashish Kumar sir needs no introduction. Almost all of the educational webinars, he will be there. And like me, that PG, can I go to
Previous slide, please.
and sir in UG, PG revision courses, and now also he is traveling all over India in teaching students. He is what to say, his love is medical education. That's what I should say. And you should see him teaching CPD. I'm fond of that chapter by Ashish sir. When I told him, he said, "No, I will talk today. Hypertension." I said, "Okay, sir. Maybe the next time we will talk on CPD." And he's a principal and professor and unit chief Facetious College of Obstetrics, Gynae and Child Health, Kolkata, and Vice President of Foxy in 16 and 17, Governing Council member of ICOG 21 and 23, and past President Bengal Gynec Society, and ex-chairperson Medical Education Committee Foxy, Scientific Chair of AICOG 2023 in Kolkata, and WHO Fellow on Maternal Health. Such a vast experience. We are blessed to have you, sir. Over to you, sir.
Ma'am, I would request you to also introduce our chairpersons.
Yeah.
We have Dr. Deepa ma'am, Dr. Sheetal ma'am, Dr. Gopal sir, and Dr. Kokila Desai ma'am. And Dr. Kokila ma'am also has a few words to talk about the speaker for today.
Okay. We will.
Can you introduce
the
them, ma'am?
chairperson. Yeah. Dr.
Yes, ma'am.
Deepa, she's the associate professor of Vadodara and past secretary of Obstetric Gynec Society and vice president of Baroda Obstetric Gynec Society. Welcome, Dr. Deepa. And Dr. Sheetal is a consultant, Shalby Multi-Specialty Hospital, Vapi. She's a current president of OBGYN Society, Vapi. Welcome, Sheetal. And Dr. Gopal sir, I just called him a few days back. He said immediately, yes, he's a senior consultant OG and medical director of Shushusha Hospital, Nalbari, Assam, practicing OG, infertility and gynec laparoscopic surgery for the past 25 years, has a special interest in emergency obstetrics, vaginal surgery and NDVH, and many national conferences he has attended as a faculty. He is a president of Nalbari OG Society, life member of IAGE, life member of IMA, and ex-secretary IMA, Nalbari branch. Welcome, Dr. Gopal, sir. And Dr. Gokila, she's the owner of Shivam International IVF Center and Vaishali Maternity Center. 25 years of experience as an OGCN and 11 years of experience as an IVF specialist. Currently the president of Surat OG Society, and she's an organizing secretary in 2024 Fertivision National Conference. And she has also served as a chapter secretary in the Gujarat IFS from 22 to 24. Welcome, Dr. Gokila.
Ma'am, can we request you, Dr. Kokila ma'am, to also say a few words and introduce the speaker before he starts his speech, ma'am?
I think I'm unmuted. Mute me.
You're audible now, ma'am. Now you're muted, ma'am.
Unmute.
Ma'am, you're muted.
Yeah.
Yeah.
Welcome. Good evening, everyone. Welcome. It's great honor to give the introduction of Dr. Ashish Kumar Mukhopadhyay. He's a renowned obstetrician and gynecologist at Kolkata. He has worked as a professor and unit head in obstetric and gynec department at CSS College and Child Health at Kolkata. He was Vice President Foxy 2016 and 17, ex-chairperson Medical Education Committee Foxy. He was a scientific chair at AICOG 2023 when it was held in Kolkata. He's a WHO fellow and of maternal health. I welcome you, sir. Today, he will enlighten us about the hypertensive disorder in pregnancy. What are the newer guidelines? What are the newer molecules available? And what are the side effects of the newer molecules? And how to control the hypertension during the pregnancy. So let's start. Welcome you, sir. Please.
Good evening, everyone, and a very, very warm message from Kolkata. Myself, Dr. Ashish Kumar Mukhopadhyay. I have been introduced twice, but what is very interesting here is the pan-India presence of the chairpersons and the stalwarts from different corners of the country, and their credit goes to the two conveners. One is my very favorite Dr. Vijaya, and another is the debate specialist, Dr. Madhupriya. I think both of them have done wonderful job, and in collecting, it really some effort has gone behind arranging this webinar. I'm really thankful to all the organizers and also my respectful regards to the chairpersons. So with that, I'd just like to see whether I can share my screen. I'm audible, I believe.
Yes, sir.
Yes. So if I want to start this thing, can you now see my screen?
Yes, sir.
I'll make it full screen.
Yes, sir.
Is
Yes.
it visible now?
Yes,
And
sir.
I'm
Very
audible?
clear, very clear.
Okay. Okay, so with that, I think I'll start a very, very difficult topic today. And I don't know how much can I do justice to this topic because the time is limited. But the things that I need to say is unlimited. It is impossible to finish this vast chapter within a span of time. Anyhow, but I will try my best. So all of us know this, the incidence officially it's 5 to 10% pan-India. But there is life-threatening morbidity involving multi-organ dysfunction. That is the key factor of this condition. And that is why, this condition remains at the top of the discussion table. 6% of preeclamptics will develop one or major systemic complications. We'll discuss them. And it contributes still 10 to 15% of maternal death. Among all maternal deaths, 19% deaths are due to hypertension in pregnancy. That was a big observation by WHO 2014, and the value hasn't decreased thereafter. In our own registry of FOXI, National Eclampsia Registry, which is done by jointly by FOXI and ICOG, we have seen the incidence of preeclampsia is 10.3%. The nationwide incidence is 5 to 10%. In our country, it's 10.3%. But I must admit, and all the learned and panelists here must agree, that there is a slight increase in the prevalence of preeclampsia these days, probably because of the brilliant diagnostic tools that we have and the clinical acumen increased of the senior gynecologists and obstetricians. Eclampsia is 1.9%. Previously, it was 3 to 4%. Now it has slightly come down. Mortality attributed to eclampsia is 4 to 6%. And what we highlight today is the risk scoring, that is the gestosis scoring, which I'll come to that later. Now, having said that, HDP, hypertensive disorder in pregnancy, is a real challenge. Why? The diagnosis is often missed because it's a silent condition. Even if the diagnosis is done, say in time, the course is unpredictable and the severity is underestimated because you can never predict which one will go into what. And even mild variety will go into severe very quickly. The improper use of antihypertensives, I think that is also a very important issue. And substandard care leads to serious complications. Then development of severe preeclampsia in early gestation, that is early onset preeclampsia, poses a real great challenge. So these are the challenges in front of us. Now let us begin by saying that the hypertension in pregnancy is a linear term. It's quite straightforward in definition. Whenever the systolic blood pressure crosses 140 and diastolic blood pressure crosses 90, we call it hypertension in pregnancy. It's a very fairly straightforward terminology. But when you say hypertensive disorders of pregnancy, the entire situation changes. So the present nomenclature is HDP, or hypertensive disorders of pregnancy, and we have done away with the nomenclatures like preeclamptic toxemia, pregnancy-induced hypertension, and so on and so forth. We have all abandoned those terms in favor of HDP. 2012-13 was the year which we call watershed line in the diagnosis and management of severe preeclampsia, because that is the year in which ACOG came together and they defined, or rather redefined, the diagnostic criteria for preeclampsia. What was that? We all know the blood pressure was there and proteinuria was there in the diagnostic criteria. The third component, that is the edema, has lost its significance from 1990s. when we saw that the edema, including generalized edema, was associated with above average fetal outcome. From that point onwards, we have abandoned edema as a diagnostic point. Now, in 2012-13, what happened? They put an OR over here. ACOG put an OR, this red circled word, very important word, OR, in the absence of proteinuria, new onset hypertension with the new onset of any of the following. That means proteinuria is no longer the mandatory criteria for preeclampsia now. And on this issue, both sides of the Atlantic agreed. I mean, the British and the Americans, they have agreed that yes, proteinuria may not be there, but still the lady can have preeclampsia. So what remains in your hand, basically, the blood pressure remains, elevated blood pressure, which would be there. Along with that, so long we have been taking proteinuria as a hallmark of preeclampsia, now it is no longer there, but the presence of any one of the 5 conditions listed below are essential to stamp a diagnosis of preeclampsia. What are them? One is thrombocytopenia, and mind you, this is not gestational thrombocytopenia, and the traditional definition of thrombocytopenia of less than 1.5 lakhs is replaced by platelet count less than 1 lakh per microliter. That's an important change. Secondly, the renal insufficiency is marked by the serum creatinine concentrations greater than 1.1 milligram per deciliter, or a doubling of the serum creatinine concentration in the absence of other renal disease. Impaired liver function is reflected by elevated blood concentrations of transaminases SGOT and SGPT to more than twice its normal concentration. The fourth criteria is the pulmonary edema, which, if untreated or undetected, may lead to lethal condition. And last but not the least, cerebral or visual symptoms. So today, to define preeclampsia, you have to have a blood pressure high, not only blood pressure high, but also you need to have any of the 5 conditions like thrombocytopenia, renal insufficiency, impaired liver function, pulmonary edema, cerebral or visual symptoms. Now we slowly understand why the hypertensive disorder in pregnancy is different from hypertension in pregnancy. This is the reason, because of the multi-organ dysfunction. That is the key difference between the hypertension in pregnancy and hypertensive disorders in pregnancy. I hope I have made myself clear. Now, it has got its own classification in pregnancy. Hypertensive disorders in pregnancy has its own classification. All of us know this, so there is no point repeating them. What is important is the relative prevalence. Like gestational hypertension, all of us know the definition. I'm not going into that. 6 to 7% of the pregnancies. Preeclampsia, eclampsia is 5 to 7% of pregnancies, and we believe it is higher than that. Chronic hypertension, which is already existing hypertension, is 1 to 5% only, but preeclampsia can be superimposed on this chronic hypertension in a more number of cases. That is roughly 1/5 of the cases, the preeclampsia is superimposed on chronic hypertension. It is very difficult to diagnose which one is the superimposed preeclampsia, because the patients often do not carry the history along with them, or the history of hypertension, etc. So it's very difficult for us. This is another challenge. Traditionally, preeclampsia is described as 2-stage disease. It develops in 2 stages. The first stage is a faulty trophoblastic invasion. We all know that there is trophoblastic invasion of the decidua, and that happens in 2 phases. That means the first phase is around 12 weeks of pregnancy. Second is around 14 to 16 weeks of pregnancy. This stage is preclinical. The stage 2, that means the consequence of this stage 1, is caused by the release of placental factors into the maternal circulation, causing systemic inflammatory response. Minding what is the systemic inflammatory response? And preeclampsia today is considered as the inflammatory response to all these cytokines that are placental factors that are liberated into the placental bed, and endothelial activation that result in a fetal growth restriction and multi-system disorder. Fetal growth disorder restriction is no longer included in the definition of preeclampsia, but it used to be used previously. So these are the 2 components, and this is the picture that will clarify what happens at the placental bed. The most frequent finding is decreased or absent second wave of trophoblastic invasion. That means in the second wave means a wave when the deciduomyometrial junction and the myometrium proper is invaded by the trophoblast. And that way, all the vascular channels are widened, maternal spiral arteries. And in comparison with the normal pregnancy, they do not remain dilated and they remain constricted. This has been evidently proved by the placental bed biopsies. Non-converted spiral arteries, muscular and narrow placental hypoxia due to reduced maternal blood flow in the intervillous space. So there's a failure of the maternal uterine spinal arteries to convert into wide sinusoids, the normal physiology of a pregnancy, which is shown by this lower photograph, where the blood vessels are dilated in order to reach more blood to the fetus. This doesn't happen in preeclampsia, and the reason being the absence of the second wave of trophoblastic invasion, which has been proved histologically now. So having done with the pathogenesis, let us come into the angiogenic factors. Now we all know that these angiogenic factors are released from the placenta. They contribute to the endothelial cell dysfunction, and they alter the balance between the circulating levels of the angiogenic and anti-angiogenic growth factors. They're always in sort of balance, While the angiogenic factors, they tend to promote the growth and development of the placental bed and good circulation to the fetus, the anti-angiogenic growth factors, they pull it back and they cause harm to the fetus in the long term if this continues. And these are, one is vascular endothelial growth factor or VEGF. Second is PLGF, a placental growth factor. And the third one is SFLT1 or soluble FMS-like tyrosine kinase 1. All these things are important because when you go into the prediction of preeclampsia, then these things will show its importance. And also another factor which is called soluble endocrine. SFLT1 is known to bind to and inhibit the VEGF and PLGF activity. So they are always at contradiction, at daggers drawn during pregnancy, and this is happening silently at the placental bed. So in short, the pathophysiology from the mother's point of view is that there are narrowed blood canals, placenta becomes hypoxic, and any hypoxic structure, insufficient perfusion will lead to the release of pro-inflammatory cytokines or factors, which will damage the maternal endothelial cells. And now you can see that the endothelial cells have become like sieve-like structure. The vascular resistance increases and preeclampsia develops. From the fetus point of view, the same poor placentation is there. The blood canals are narrowed, placenta becomes hypoxic, up to this far is the same. Redistribution of the fetal blood flow happens in order to save the vital organs of the fetus. So the blood flow at brain and the heart will increase, placental flow is decreased, and the vascular resistance increases, and that also results in preeclampsia. So two-way contribution to the preeclampsia, and the lady suffers silently. Coming quickly to the prediction and prevention of preeclampsia. We have been trying this for a century, maybe, I don't know. Seeds of this multi-organ dysfunction is laid down in early pregnancy. That's quite clear now. And therefore, it's pertinent that we try and detect this in first trimester or early second trimester at the most. That's our job. Unfortunately, it's extremely difficult and certainly not cost-effective for a huge number of general obstetric patients we are so used to see in our OBGYN, OPD, or IPD. Like all of you are facing the patient workload in your hospital, and today the load has increased because of the institutional delivery, which in our state is 99%, must be the similar in all your states. So prediction of early preeclampsia is not only difficult, it is not cost-effective also. Let us discuss. Let us identify the tests that are not useful today. They have been proved that they're not useful. Biophysical tests like angiotensin II challenge test, Gantz test or the rollover test, supine pressure test, isometric exercise test. There are so many tests that we used to, since they were published in 1990 British Journal, we used to practice them, but all have proved to be futile. Uric acid has been promoted as a marker of preeclampsia for quite some time, erroneously so, because the sensitivities range from 0 to 56%, and something which has a sensitivity of 0 cannot be accepted as a predicting factor. Inherited thrombophilias like factor V Leiden mutation, prothrombin gene mutation, protein CAS deficiency, and antithrombin deficiency. And ERA went into all these costly tests, which he used to do on the patients. Unfortunately, they produced no result, not associated with preeclampsia. And similar was the result with the antiphospholipid syndrome. Screening the general obstetric population for APLS is not useful and not at all cost effective. So we abandoned that also. So all these old methods of prediction were gone. So what is useful and what is practically feasible screening tests? Now, like we have always said that go back to the basics. We tell our students, go back to the basics. We say measurement of blood pressure at each antenatal visit starting in first trimester is very, very, very important. There is an organization which is called USPSTF, or United States Preventive Services Task Force. They have been working along with the UK organization since 1990 on control of hypertension during pregnancy. They have contributed very significantly in the control of hypertension during pregnancies, but in two different ways across the Atlantic. Blood pressure measurement at each prenatal visit appears to be as reliable as self-monitored blood pressure. Here lies the importance, because the same machine today, I'll come to the machine of blood pressure a bit later, for early detection of preeclampsia, that's the basic value we need to have for each and every patient. That means our blood pressure in the first trimester. Unfortunately, we can't get that in most of the occasions. 30% of the participants had discordancy between the home and office readings, most of which were attributed to white coat hypertension. What is that? Whenever the lady sees a person in a white coat, they develop, panic reactions and the blood pressure goes high. But even a single episode of white coat hypertension is associated with preeclampsia. Those cases have been reported also. But the story is incomplete. Why is it incomplete? Historical risk factors only predict approximately 30% of the patients who will develop preeclampsia. So laboratory and imaging tests in combination with historical risk factors, the blood pressure, to calculate a patient risk will be necessary. However, the current risk factor prediction models have low positive and predictive value also. So there lies a difficulty. So we resorted to biomarkers. Now, what are the biomarkers? We've already discussed about VEGF, PLGF, and ACNG and SFLT1. If we can measure them, well, it could be an indication that the things are not probably going in the right direction. The trophoblast, which is vascularly compromised, a characteristic finding in preeclampsia, increases production of anti-angiogenic proteins like ACNG and SFLT1 and reduces production of the good factors like VEGF and PLGF. Now, these alterations in the absolute levels and also the ratios, particularly SFLT1 and VEGF or PLGF, is very, very significant. And so SFLT1 is to PLGF ratio may be the best test for predicting preeclampsia and the adverse outcomes in preeclampsia, but it's not very useful early in pregnancy because they take time to develop. But we want something which has to happen in the first trimester or in the early pregnancy, before 20 weeks of pregnancy. Unfortunately, nothing is in sight for the prediction of preeclampsia. How good or bad are these? In 2022, an international expert group concluded that the SFLT1 PLGF ratio test could be used as a tool for short-term prediction of preeclampsia. But the time of testing, that's the time of the gestational age of testing, between 20 and 36 weeks of gestation. That was published in 2022. Urinary PLGF also does not perform well in early pregnancy as a screening test. So the trouble continues, and we don't find anything good enough for the early part of the pregnancy. PLGF, incidentally, enjoys a very good position in the biomarker category. And this has been accepted by UK guidelines. Published in Hypertension 2017, it has got a critical level of 100 picogram per ml and a lethal level of 50 picogram per ml. Any further reduction in value will go into fetal demise. So PLGF and SFLT1 combined with SFLT1 continues to enjoy a good position as of now today. What are the other lab tests? Maternal serum annihilates. They are called serum annihilates like PAPE, cell-free DNA. All of you know about this. There is no scope of detailed discussion here, but the use of uterine artery Doppler velocimetry for prediction of preeclampsia was best illustrated in a systematic review of 74 studies, including almost 80,000 participants. That's a big number. Urinary Doppler ultrasonography was more accurate for prediction of preeclampsia when performed in the second trimester than in the first trimester. So that's better than the previous ones. But it has got a high false positive rate. So nothing comes with, with honors mark, they're all pass marks. So different models developed, like full Pire's model, combining all these conditions together. And they were subjected to cohort studies in 2023. And also the different lab values like creatinine, ASLT, LLT, etc. There were different models, either a full Pire's model or a PREPES prediction model. However, these models are running better in UK and not running in our country, so I won't discuss them. Now let us come to our own indigenous scoring system, that is Gestosis score. What is Gestosis score? Developed by the World Gestosis Organization, and they attribute score of 1, 2, or 3 to different conditions. And all of you know this, and any standard textbook or online is available. Like age is an important factor, either a teenage or an advanced stage risk factor 1. Maternal anemia, which is roughly in 50 to 60% of our women. Obesity, primary gravida. Short duration of sperm exposure or cohabitation, DS score 1. Women born as SG, women themselves, family history of CV disease, PCOS, etc., and mean arterial pressure more than 85 millimeter mercury. Risk factor 2 are given to maternal hypothyroidism, family history of preeclampsia, gestational diabetes mellitus, obesity when the BMI is more than 35, 2 score, multifetal pregnancy, 2 scores, and hypertensive disorder in pregnancy, in previous pregnancy, 2 scores. So family history is different, and previous pregnancy hypertensive disorder, both attract a score of 2, and both are important. So history is so very important. Risk factor score 3 is given to pregestation and diabetes mellitus, chronic hypertension, mental disorders. That means you have to take the history of drugs taken by the patient properly, or visit to a psychologist or a psychiatrist. Inherited thrombophilia, all of us know this. Maternal chronic kidney disease, of course, a risk factor of I category 3. Autoimmune like SLE, APLA, or RA, and pregnancy with ART and with or surrogacy. So all these things are risk factors with score 3. Now, what is the junctional point? The junctional point is risk factor is 3. So whenever the total score crosses 3, if you have one of these factors, the score easily crosses 3, and she is under the threat of developing preeclampsia in later pregnancy. Fetal Medicine Foundation in UK also had some risk prediction modules of their own. It's guided by an app, and if you put some findings into the app, they will calculate the risk for you. This is called FMF risk prediction model. This is also quite reliable, but you need to have an ultrasound, NT scan, and dual markers at 11 to 14 weeks. The mean arterial pressure, uterine artery PI, and serum PLGF. For PAPE, when the PLGF is not available, if you don't get PLGF, you can use PAPE in its place. The values for PLGF and PAPE depend on maternal characteristics and reagents used for analysis, and they therefore need to be converted into multiple of medians. That means moms. So all these things are there, and you can easily find out these risk prediction modules by FMF, which has been widely circulated, easily available on the net, and easy to calculate. Just put the values and you'll get the risk factor scoring. These are the clinical risk factors. All of you know that we have discussed them. So I think there is no point discussing them again. 2019, FIGO came out with a very good publication. And the pragmatic guide for the first trimester screening and prevention. And they have mentioned all these things, what I have discussed today in that article, in which one of the authors were our Hema Dibakar. And I think that it's a very good read. If you have time, you may go through this. Come to the prevention. What are the effective interventions which can prevent preeclampsia? That has been established now. Well, prediction may be at some point, at some, controversy, but interventions which will prevent the preeclampsia are quite well established. For instance, low-dose aspirin. What is low dose? I'll come to that later. But approximately 10 to 20% when given to women at moderate to high risk of the disease, it has got an excellent maternal fetal safety profile in pregnancy. The rationale is that it diminishes the platelet thromboxane synthesis, platelet aggregation, while maintaining the vascular wall prostacyclin synthesis. So whenever there is some problem in the microvasculature, vascular wall, they promptly go there and they remove all those things and keeping the endothelial wall perfect or near perfect. And thereby the irritation of the vascular endothelial factors and modulation of inflammation is stopped, which prevents preeclampsia. There was a meta-analysis 2019, 74 trials, more than 40,000 women across the range of low, moderate, or high risk of preeclampsia with prophylactic use of antiplatelet agents, primarily low-dose aspirin. And this was published in Cochrane Review 2019. So this is established now. Now, how low is low? That we have to discuss. What are the effects of this low-dose aspirin? They reduced all the fronts of preeclampsia, proteinuria preeclampsia, fetal or neonatal death, overall preterm birth less than 37 weeks, that's a boon, small for gestational age, and serious adverse maternal and neonatal outcomes. And look at the risk odds ratio, that is 0.9. A 2021 meta-analysis by the United States Preventive Services Task Force, USPSTF, which I mentioned before, reported similar data, but little or no difference in the risk of HELLP syndrome, SAM, or NICU admission. So all these factors are unaffected. I mean, the result is unaffected. That's the only criticism to this type of, prevention bids. But it is there. I think we can try that. Whom to give aspirin? For that, the trial recognized was ASPRE trial. It showed 62% reduction of preterm preeclampsia. And these are the high-risk factors. Any one of them will be enough for starting preeclampsia. Previous pregnancy with preeclampsia, type 1 or 2 diabetes mellitus, chronic hypertension, multifetal gestation, kidney disease, or autoimmune disease. And for a moderate risk factors, you need 2 factors, 2 or more. One is nulliparity, second is obesity, then third is family history. So self-history is major risk factor, a high risk factor, but family history is a moderate risk factor, according to ASPRE trial. Age more than 35 years, socio-demographic characteristic like black persons, lower income level group, etc., etc. And there are some personal risk factors, like small for gestation age, etc. So these are the candidates with whom you start the aspirin. But timing is very important. It has to start prior to 16 weeks of pregnancy. FIGO recommends at 11 to 14 weeks. I wonder how many patients of preeclampsia or potential preeclampsia you will get at this age of pregnancy. Timing of discontinuation, there is no consensus. Most will discontinue at 36 weeks, but many will continue to delivery or 5 to 10 days before delivery to diminish the risk of bleeding during delivery. However, no adverse maternal or fetal effects related to the use of low-dose aspirin at delivery have been proven. Now, there are some recent studies, also 2022, a Lancet publication, in which it also shows that it, along with the progesterone, it prevents the preterm labor also. So that is one thing that is always in discussion, that when to stop the low-dose aspirin. In the 2019 meta-analysis discussed above, trials using dosage more than 75 milligram appeared to show a greater risk reduction for preeclampsia than trials using dosage less than 75 milligram. So LDA dosage, low-dose aspirin dosage, is always a matter of controversy. And there are many countries using many doses. NICE guideline always used 75 milligram. Even many in our country believe that. And at least 2 moderate risk factors and high risk factors, as I've mentioned. But USPSTF, ACOG, and SMFM, Society for Maternal Fetal Medicine, they all recommend 81 milligram per day and continue daily until delivery. WHO recommends the use of low-dose aspirin 75. Canada has recommended the range 75 to 162. FIGO recommends low-dose aspirin for women identified as high risk, and recommended dosing is approximately 150 milligram, beginning at 11 to 14 weeks, and the time when you do the NT scan and dual marker, and then taken every night after dinner until 36 weeks of gestation, delivery, or diagnosis of preeclampsia. So that is the FIGO recommendation, which all of us should remember. And I think that currently the dose for prevention of preeclampsia is 150 milligram nightly. So this is the Lancet publication that I was talking about. Low-dose aspirin is known to reduce the risk of preeclampsia in high-risk women, and they can prevent preterm birth also, less than 37 weeks, less than 34 weeks also. Look at the range of reduction. Preterm birth less than 37 weeks is reduced from 11.6% to 13.1%, and preterm birth 34, 3.3% versus 4.0. I mean, reduced to 3.3. Perinatal mortality is also reduced compared with placebo therapy. So now you think about, would you like to stop aspirin at 36 weeks? Because the next day the labor may start, and therefore, I think it is better to continue beyond 36 weeks also in our setup, where the preterm labor rate is quite high. Safety of low-dose aspirin has been established. There were some concerns about long-term safety profile, particularly some cases reported about gastroschisis, but they didn't stay for long. And I think it is quite safe. And that was established by the CLASP trial and the ISAP trials. Both of them have established that it's quite safe. There are some additional measures which we can, apart from low-dose aspirin, is calcium supplementation. Calcium supplementation was initially recognized by WHO in 2011, and it said in its publication that if a country is calcium deficient, our country is, there a high-dose calcium in the range of 1 gram twice daily or 2 grams per day is recommended. Along with the other features are quite useless, like weight loss, exercise, statins, etc. And of course, low molecular weight heparin is not recommended. So these are the prevention techniques that we can have. And all these are useless, so I'm not going into the fish oil, the dietary salt restrictions, and they may be harmful even. Bed rest also is harmful because the chance of VT is higher in the preeclampsia patients. So I will never recommend bed rest. And also L-arginine plus antioxidant, the new coming up molecule on which the pharma industry shouted quite a lot during some period of time. They have started, becoming silent nowadays. Clinically, we have two different types of preeclampsia. One is early onset, that means before 34 weeks, and another is late onset after 34 weeks. Essentially, these two are completely different, although clinically not much discernible always, because the period of gestation itself is in doubt always. Because early onset preeclampsia, as I said in my initial slide, it's a fetal disorder that is typically associated with placental dysfunction, whereas late onset is a maternal disorder due to underlying maternal constitutional factors. IUGR is there in before 34 weeks, whereas late onset doesn't see much of IUGR or FGR, low birth weight versus normal birth weight in late onset preeclampsia. So if you are allowed to select of the early or late onset, you'll always select late onset preeclampsia. Now, what is new about the severity classification? In the beginning part, I said that preeclampsia's course is unpredictable. Now, you never know what is mild today, preeclampsia today, like 140 by 90 up to 159 by 109 millimeter mercury. That is traditionally called mild preeclampsia previously. That may throw convulsion the very next day. And the patient have died, on the way going back home. So therefore, the term mild was, done away with. It was eliminated. So there is nothing is mild these days. So you call it non-severe and severe. That's the recent 2019, RCOG recommendation about the classification or the severity classification of preeclampsia. So today, nothing is mild, either is a non-severe or a severe preeclampsia. When do we admit the patient to the hospitals? They depend on the risk prediction models, but we don't depend on that. We depend on the period of gestation and the control of hypertension. We'll come to that a bit later. Now, the question is how frequently we do check the blood pressure. Blood pressure checkup, the aim of the blood pressure is 135 by 85 millimeter mercury. At least every 48 hours should be checked. In case of severe, it is every 15 to 30 minutes. How do you do that? Every 48 hours, if you want to check the blood pressure, obviously the patient has to check it herself at home. Otherwise, it's not easy for a woman to come to the hospital every 48 hours just for checking the blood pressure. So measuring blood pressure is no mean task. I mean, we have always delegated the task of measuring the blood pressure to the junior most intern in the system. And they, without knowing the significance of the hypertensive disorder in pregnancy, they used to just record the blood pressure, and maybe only on one occasion, and they used to take opinions, pass opinions on them, without caring for the fact that there can be white coat hypertension, patient may be tense, she hasn't rested for last night, etc., etc. Even positions like left lateral position is not done these days. They may yield false positive, falsely low values. So sitting position is recommended these days. Why? Because that's the position she assumes almost 90% of the day. So what are the prerequisites for a blood pressure measurement? The bladder should be empty. The question is whose bladder? It's the bladder of the patient, but the doctor also should empty her bladder, I believe. Quiet environment in a comfortable room. Now you understand how much comfortable a room can be in an OPD, in particular in a public hospitals. Patient in sitting position with no crossing of legs, that's manageable. No tight clothing on arm or forearm. Yes. No anxiety, stress, or pain. I don't know how much it is possible. Patient should stay silent prior to and during the procedure. That's very difficult because all our patients are ladies. No caffeine, smoking, or nicotine in the preceding 15 to 30 minutes is manageable. No nasal decongestant or eye drops. So some of them are comfortable, some of them are non-manageable. About controversies about the Korotkov 4 sound or Korotkov 5. Ideally, Korotkov 5 should be taken as a measure of diastolic blood pressure, but in approximately 5% of cases, you will see that the diastolic blood pressure goes up to 0. Now, 0 cannot be a diastolic blood pressure, so we have to elevate the blood pressure level once again and come down and stop at, or rather, take the recording at Korotkov 4. That happens rarely, but you should remember that.
So sorry to interrupt, sir. Last 2 minutes, sir.
Okay. Then
Thank you, sir.
I'll wrap it up. Okay. So blood pressure machines is another problem because nowadays the sphygmomanometer you cannot use because of the problem from the pollution control board, and the calibrated Android devices are not very well. So ultimately the machine that we use today is the automated BP machine, which the patient also uses that machine. So self-monitoring of blood pressure is easily possible. So weekly appointments for if hypertension is poorly controlled, and appointments every 2 to 4 weeks if hypertension is well controlled. Investigations, all of you know, so I'm not going into that detail. But remember, complete hemogram is a must. And the liver enzymes, renal function tests, platelet count, as I said in the beginning, coagulation profile is only when the platelet count is less than 1 lakh, not otherwise. Serum electrolytes and peripheral blood smear showing hemolysis. Fundoscopy is a must. So these are the investigations. Okay, now I will quickly skip these slides of target blood pressure. I've already mentioned that 135/85. Aim for this blood pressure level or 2 millimeter mercury. This side, that doesn't matter. About proteinuria, what changes have been there? Today, the assessment of proteinuria, as I said, that the importance of proteinuria has gone down, but interpret proteinuria in the context of a full clinical review of the symptoms, signs, and other things, and do not depend on proteinuria alone for the diagnosis of fever preeclampsia. Protein creatinine ratio, however, is a good marker, and all of you know the cut mark, that is the borderline mark is 0.3. Now, I will skip all these things because the antihypertensives in PIH is a big issue, and when to deliver these two, I'll just focus upon because the time is limited. The NICE guideline says that when using medicines to treat hypertension in pregnancy, aim for a blood pressure 135/85. And these drugs which we use, there are many classes of drugs, but remember, all the drugs are category B drugs. And therefore, you should have some drug which will, and this is the control the blood pressure effectively without affecting the systemic circulation. Consider labetalol to treat chronic hypertension in pregnant women. Nifedipine is also good, but methyl dopa, once upon a time, it was a gold standard, is no longer used nowadays. In fact, it's not available in the market also. So I will skip all these slides, and the ideal drug for the pregnancy hypertension or hypertensive disorder, labetalol, and the infusion start, all of you know this, we have been using it daily, 20 milligrams, some start with 10 milligram, repeat 20 to 80, 80 to 160, and then up to ultimately 300. Other drugs we have rarely used do not offer planned early birth before 37 weeks. It doesn't help. And this is the trial of two trials which have established that. One is HyperType 1 trial and another is HyperType 2 trial. So induction of labor is the mechanism of delivery in these cases, and there should be aggressive induction attempts for the delivery. And there are some things which we should, government should be offered induction to everyone. Dinoplaston gel is a very important choice. These are the maternal fetal complications, all of you know. I'm not going through them. And then I will go to the last slide because all these things, we all of us know about the Duesman's regime or the Pritchard regime of eclampsia. I'm not going into them. But the indication of CT scan in an eclampsia patient is important. If there is a recurrent eclampsia or convulsion, then you should go for a CT scan. These are the monitoring of the thing and therapeutic range. You must remember that feeling of warmth, flushing, double vision, slurred speech is 3.8 to 5 millimoles per liter. Loss of tendon reflexes is more than 5. Respiratory depression more than 6. Respiratory arrest is 6.3 to 7.1. Cardiac arrest happens in more than 12. So magnesium sulfate enjoys a wide window of safety for all our patients. So don't be scared. These are the indications for CT scan: recurrent seizures, focal neurological deficit, very poor unresponsive general condition, blurring of vision. HELP syndrome I won't discuss much because that everyone knows by now. And I think we will go to the last slide now about the anesthesia and analgesia. Avoid general anesthesia. All of you know why. Risk of general anesthesia, all of you know. But be careful about the regional anesthesia also because there could be profound hypertension at times. Postpartum is always neglected. Therefore, monitor the patient in HDU. Continue magnesium sulfate for 24 hours. Proteinuria often persists. Postpartum thromboprophylaxis is extremely important. So what is the antihypertensive choice after this thing, postpartum period? Enalapril is a good choice as per NICE guidelines 2019. Do not attempt to normalize the blood pressure, never. No diuretics before delivery, but it is mandatory to give diuretics after delivery in such patients. So I think we will go to the conclusion slide, take home message. I think these are I have already discussed, nothing more to discuss. They are the references. Thank you very much for your patient hearing. Thank you.
Thank you so much, sir. A good presentation and it needs a lot of time. I understand, sir.
Yeah.
Coming to the risk and screening only, it takes 1 hour. And then I think we should ask, sir, again for the clinical symptoms and management, when to start tablets and injections, all those things. And also the trials, the HyperType 1 and 2 trial. Maybe sir will be called later after 1 month. Maybe sir is very busy. With great difficulty, he accepted this. Thank you so much, sir. It was such a wonderful presentation. And it will be uploaded in the YouTube, sir. So even the students who have missed, they can see the slides, sir. No problem. Thank you, sir.
I told you in the beginning, it's very difficult to do justice to the subject in 30 minutes or so, because the hypertension itself develops so much time to develop.
Sir, sorry to interrupt you, but I'm Dr. Sheetal Tadekar, and I really want to congratulate for covering such a vast topic in such a short time, and you covered each and every point, sir. So, and this is good that is going to get uploaded on YouTube. One question I had that till what time postpartum shall we continue with antihypertensive? As you said that we should not try to normalize the BP like baseline. So what is the ideal BP we should be achieving and till what time postpartum, how many weeks, and what is the drug of choice?
It's a very difficult question, you see, because each and every patient requires sets of time to return to the normal blood pressure, so-called normal blood pressure level. Some of them will never know what is the pre-existing blood pressure level. So it's very difficult to understand. Only thing is that by government of India guidelines, 48 hours to 7 days is the window during which you should always observe the patient by any which way you can. Suppose you are confident about the patient's education, their economic condition, etc., etc. You can release her after normal delivery, vaginal delivery. You can release her after 48 hours. That's a government guideline. But then you should have a mechanism there so that somebody measures the blood pressure in the same interval, 4 to 6 hours interval at home. So that is mandatory. And about the antihypertensive, actually we switched the antihypertensive from labetalol, which has been an ideal for because of the dual action, you know that. But during the postpartum period, it could lead to a sudden fall of blood pressure. There's nobody to monitor that. And therefore, we prefer enalapril.
Yeah.
These days, we use enalapril. You can also use amlodipine because that's a long acting. Simply because you will not get enough time. In a short span of time, everything happens. And postpartum, there are huge changes in the circulation, which actually affects the blood pressure. That's the problem.
Yes, thank you, sir.
Thank you very much.
Yes, sir. Thank you so much, sir. And we can take up the question in the chat box too.
Yeah.
And thank the chairpersons, Deepa, Kokila, Sheetal, and Gopal, sir, for being the chairperson for this session. Sir,
Yeah,
we'll
thank you,
go to the
ma'am.
next session, sir. Thank you so much, sir.
My
Yeah.
pranam to all the chairpersons. I'm sorry I couldn't
Thank you,
make
sir.
each of
Thank
you.
you, sir. You have
And
covered.
Thank you, sir.
Thank you.
Thank
You
you
are
for
such
making it.
wonderful people that you have tolerated me for long 35
No,
minutes.
Very,
sir.
very
I'm
You are,
very grateful.
It
was a very
we are
interesting
very
session.
glad to
Very
that
good answer.
Ashish
Very
sir
well.
has delivered it.
Yes, sir. Thank you, sir.
All
Madhumita? Madhu?
Yes, ma'am. Yes,
Ah.
ma'am. We can go ahead with the next session now. Can I have the slides of the chairpersons, please? We'll have the chairpersons introduced for the second session by Dr. Vijaya, ma'am. And at the end of the introduction of the chairperson, I request the speakers to be introduced too, please. Can I just ask Madam Dr. Archana Rathod, Madam, to introduce the speaker at the end of the chairperson introduction? Thank you. Ma'am, can you
Yeah.
please introduce the chairpersons, ma'am?
Yeah, welcome to the second session, the very much awaited session. Dr. Kiran Chandana, she is my dear friend, and she is President Faridabad Obstetric Gynec Society, and she was Vice President of Faridabad Menopause Society and Joint Secretary of her OBGYN Society. And she's an organizing chairperson for many of the events, and she was the faculty in various conferences. I've seen her in Chennai so many times. She's a national coordinator for MTP committee, Foxy. She's done lots and lots of work in MTP, contraception, and adolescent health. Welcome, Dr. Kiran.
Thank you, ma'am.
And Dr. Kunika, I spelled her as Kanika. Then she said, Madam, I'm Kunika. So, gynecologist, IVF specialist, and director of Vardhan Nursing Home, assistant professor of PGIMS Rokta, and she was ex-senior MAMC Delhi. And first IVF baby in Palwal. Oh, great. And multiple publications in national and international journal. Member of IMA, IFS, IZAR, and president of Palwal Obstetric and Gynec Society. Welcome, Dr. Kunika. And Dr. Aburba, he's a MS Gold Medalist and Medical Director of Durga Clinic and Fertility, Chairperson of the Sexual Health and STA Committee Foxy 24-26, editor of Foxy Focus, Gyan Deepika and Sexual Health, and he chaptered more than 10 textbooks and 3 orations, 10 keynote, and look at the winner list, like Guinness Book, so much a winner, such a young doctor.
Thank you so
Welcome,
much, ma'am.
doctor. Yeah, so nice of you. Thank you. Archana is a gold medalist from Mumbai, secretary of the IMA Women's Wing, Yavatmal, secretary of YOGS 2014, director and practicing consultant. I think she 2024, I don't know. Special interest in high risk obstetrics and infertility, ultrasound and endoscopic surgery. Welcome, Archana. Yeah. Can we ask one of the chat person to introduce ma'am?
Ma'am, you can go ahead introducing yourself, ma'am.
Yeah, okay, no problem. And ma'am is so patiently waiting. Sorry, ma'am, kept you waiting because the second session is a much interesting session for the IVF specialist. That is why we just put you as a second person. Madam is the chief clinical mentor of the Pan Nova IVF group, and she has a chair of advocacy committee, infertility committee, past president of IFS, past president of IMS, chair infertility committee, AOGD,
Stop this.
vice
We
president
are already
IFA,
late.
and she is the associate editor in
Let's
Journal
stop
of
it.
Global Health. Yes, madam. Teaching and
Yeah,
training,
let's
that
start.
is the important, madam. Teaching and training, and she has authored 2 books on infertility and more than 1,000 lectures and conference oration. We are very eager to listen to you, ma'am. Welcome to this webinar.
Thank you so much. First of all, thank you to all of you in this society for having me here, Vijay, of course, and then Madhulika, my dear friend, and with me in Nova. So thank you very much. And you have heard a very elaborate lecture on pregnancy hypertension from Dr. Ashish. I will not be so elaborate in talking to you now because we are all close to dinner. So I shall try to be as succinct as possible and try to finish it up quickly. So let me share my slides now. Thank you to my chairpersons also, and I will talk to them later. Two are from my part of India, Faridabad and Palwal. Happy to know that we have IVF people here with us today. Can you see my screen, please? I think it's visible.
Yes, ma'am.
Okay, so basically, we are talking about the ART Act since the last 3-4 years now, since 21, I would say, and then we are now in 25. So let us see where we are. As Madhulika said a couple of minutes ago, how are we navigating this? So you all know that in December 20, this act was enacted and we had this gazette coming in, but it was in June 2022 that we had the rules coming in the form of this gazette. And so it was, a kind of a flurry everywhere. There was total chaos and confusion, and everybody was wondering what is going to happen now because we already had the PNDT Act on our heads. And so then, why should we know this law? For those of us who are offering advanced infertility treatment in our clinics, it is mandatory, as we all know. And as Dr. Vijaya said, the IVF people. But for all of us who are seeing any infertility patient, it is also important because we should know the legal requirements of the same. And our aim should be now to identify the strengths of this act and turn them in our favor so that we don't struggle the way we have been with the PCPNDT Act. So let us do a SWOT analysis and see where we are. Let us look at the strengths, the opportunities, the weaknesses, and the threats of this act, and let us see. It actually helps us to regulate the ART in India. That is what it was meant to do, weeding out the illegal players to stop unscientific and antisocial practices, better governance, and then it gives us lots of opportunities, basically to consolidate our practices, more numbers to treat, an opportunity for research and scientific advancement. Also, if you look at the weaknesses and the threats, they are also plenty. The Act has many ambiguities, as we shall learn as we go ahead. The implementation of this act has been little shoddy. It hasn't been implemented the way it should have been, but we shall go through it again. And again, it is not very patient friendly and doctor friendly. However, what are the threats of this act? There is strict data management which is required, and that may go wrong. Severe punishment on minuscule offenses. Third-party reproduction may go awry and unavailable to those who need it. Therefore, because basically now it is going to be more restricted and more, rigid as we have in the PCPNDT Act. So now with all this, let us go ahead and see what it entails and what we are looking at. In 2005, the ICMR also gave out ART guidelines, and they divided the clinics into 3, the primary level clinics, which were meant to do only the diagnostics and basic treatment, the secondary level clinics, which had to diagnostics and treatment up to IUI, donor and self, and tertiary clinics, which had facilities for IVF and all related procedures. But there were no ART banks and there were no surrogacy clinics. All of this was done in these only. And now what has happened in the ART guidelines of 2022, 25th January, we had the National ART and Surrogacy Board, the State ART Board and the Surrogacy Board, and then the registering authority. And there were 3 types of entities which were described: the ART clinics level 1, level 2, the ART banks, and the surrogacy clinics. So here, instead of the 3 clinics, we have been divided into level 1 and level 2. And of course, we have these new entities, meaning thereby that ART banks, which were not there earlier, have come up, and surrogacy clinics, which are a part of the ART clinics, have now been separated. So what are the salient features then of this act? Classification of the entities working under the act: the ART clinic, level 1 and level 2 clinics, the ART banks, the surrogacy clinics, mandatory registration for all with the fees for renewal, mandatory staff in each with specific qualifications, defined functions and permissions for enactment of procedures, and basically lots of punishment. So essentially, it is a more structured act now. That is why I said the strengths of this act were many. It was meant to regulate the practice, but let's see what is happening and what are the ambiguities. So the process is not very difficult. It has been outlined very well. Notification of the act was in 22, notification of the boards happened, and then the rules and regulations after amendment in June 22, notification of registry and boards. Registration had to be applied with a payment within 60 days on the portal after announcement of the state authority. This is something to be noted. And when we come to the actual people who have registered, you will see that the number is minuscule. Now let us see what can happen under this scenario. We have a patient who is 19-year-old and a young man who is 21 years old. They have been married for 1 year. They are evaluated for fertility, and husband was found to have stenoteratozoospermia. They want to explore the option of IUI. As per the law, can we start investigating them for infertility? Number one, can this treatment be done at this point for this couple? And at what age can we offer ART treatment to our patients? That is very important now. That is the regulation that has happened. Infertility means the inability to conceive after 1 year of unprotected sex, which we have known for a very long time, ever since we have studied in our in undergrad days also. And the clinics shall, but what is more important is that the clinics shall apply the ART services only to a woman above the age of 21 years, she does not qualify, and below the age of 50. Similarly, above the age of 21 for a man also, and below the age of 55. So this is the specification of the age wherein this couple does not qualify because the lady is 19 years of age. Married or a single woman. So these are the two types of people whom we can give or offer them infertility treatment, that is a married couple or a single woman. It is not allowed for living relationships or single sex couples and single men, only for a single woman or a married couple. So this is what it is. They qualify as per that criteria, but however, because of the age, they do not qualify. Now, what are the pertinent questions that any gynecologist who wants to start an IUI clinic within their center or clinic, what would she want to know? What is the definition of ART according to this new law? What is level 1 and level 2 ART clinic? What are the requirements that you have to fulfill in level 1? What are the requirements for level 2? How is it different from level 1? What are the registration requirements, documentation? What is it required? Then finally, is the transfer of gametes from one clinic to another permitted under the law? Previously, semen preparation was done in IVF clinics or in path labs, and then the prepared sample used to be sent for IUI to their clinic. What is the current position of this, and what are the penalties then for contravention of this law? So these are the pertinent questions that you people would want to know, and would some of you, yes, know it already because the act has been around for more than 3 years now. However, it is not a bad idea to start revising. So here, according to this new act, the assisted reproductive technology with its grammatical variations and cognate expressions means all techniques that attempt to obtain a pregnancy by handling the sperm or the oocyte outside the body and transferring the gamete or the embryo into the reproductive system. So here the sperm or the oocyte outside the body is included. Earlier in the definition of assisted reproduction, only IVF was included world over, but now with this new definition, we are also including procedures wherein we are doing IUI in these patients. So anywhere where you're handling the semen also would come under the definition of ART. And of course, it goes without saying that written consent of all the parties is very, very much essential. What is the difference then between level 1 and level 2 clinics as per ART law vis-a-vis the ICMR law? So here what happened is that the level 1 ART clinics are those where preliminary investigations can be carried out, cause of fertility can be ascertained, and only IUI is carried out as a part of the treatment. So this is basically the level 1 and 2 of the ICMR, which has been clubbed together to form level 1 in the ART law. Now, the level 2 clinics, on the other hand, are clinics where all the procedures are allowed, including the IUI. So everything is allowed over here, and you can also carry out storage of gametes or embryos to perform any kind of procedure or technique involving the embryos and gametes. Now, these clinics can also undertake research. They should be ART clinics where all investigations, diagnostic and therapeutic procedures are carried out. So therefore, all this is allowed only in level 2, not in level 1. What are then the requirements that you must meet if you have to register as level 1? And then what are the ones that you would meet as level 2? Now, here the staff requirements and qualification in level 1 are minimal. Minimum one gynecologist, and the qualification is only a medical postgraduate in gynae and obstetrics. Then the requirements for the equipment is mainly 3: microscope, centrifuge, and refrigerator. And therefore, it is very, very simple that they have kept it. However, there are problems with this as well. We shall talk about it. Level 2, this is where you have a minimum of one gynecologist, an anesthetist, an embryologist, and a counselor. In addition, you can also have a director and an andrologist, which need to be present over here. Most importantly now, this is for all of us gynecologists to understand that if you are wanting to qualify as a level 2 ART specialist, you have to have at least performed 50 ovum pickup procedures under the supervision of a trained ART specialist with 3 years of working experience in an ART clinic under supervision. That is one part. Or you should be a medical postgraduate in OBGYN with super specialization, or doctorate of medicine, or fellowship in reproductive medicine, with an experience again of not less than 3 years in an ART clinic. So this 3 years experience and these other features are very essential. Otherwise, you cannot practice as a level 2 ART consultant. So what are the registration requirements then? For level 1, it is 50,000 as the initial fees, and for level 2, it is 2 lakhs. These are valid for 5 years, and this has to be renewed after 5 years. Remember, this is different here, and when we shall come later on, we shall understand. What is the documentation that is required for performing an IUI? Again, over here, there is a form which is available on the net in the guidelines or in the ART law. This form 7 has to be filled with every IUI that you're performing with the husband's sperm. For the donor sperm, you will find that there is a separate form. However, we will talk about it as we come to the cases. So this is one. And then the 7th question that which was coming up to our minds: can the transfer of gametes from one clinic be done? Yes, it is possible, but with the help of the permission of the national board. There is a special form available on the net under the national board website, wherein you can know how to go about and transfer these gametes from one clinic to another. The ones who are doing IVF in the present group over here would know that many of us are transferring embryos from one clinic to another. Even though in NOVA, we are working as NOVA, even for us to transfer gametes from one NOVA center to another, we have to take the permission of the national board. So that is mandatory now. What are the penalties? Remember, the penalties are as severe as they are in the PNDT law. Fine will not be less than 5 lakhs and can extend to 10 lakhs. Again, subsequent contravention, it can be punishment, imprisonment for term which may not be less than 3 years, but can extend to 8 years, and with a fine of not less than 10 lakhs, and it can extend to 20 lakhs. So this is basically a severe punishment or on any kind of penalty. So we have to be aware of this law and think about not breaking this law. So then finally, once we have revised the major things that are required from us, why are most of the gynecologists not registering for ART clinics? Why do you think there is a reluctance? And what are the practical problems in doing IUI at level 1 clinic? That is what we are wanting to understand. So this mandatory registration and the registration amount was actually a pain to many of us who felt that it was too high and it should not have been done. Doctor must be a postgraduate in gynae, mandatory staff, mandatory equipment, mandatory licenses other than ART, that is PCP and DT, also is required, even though you may not be possessing an ultrasound machine. But since you are handling the sperm, you do require a PCP and DT certificate as well. Record keeping and data entry, and mandatory data entry and monthly reporting to the authority. Remember, this has to be done every month, just as you're reporting to the PCP and DT department. So therefore, this is added work. Hence, there is a reluctance in doing all this and not basically registering for this. Also, this entire thing is going to increase the cost to the patient. So there is a reluctance to join as a level 1 clinic. Androtech again is, or a person, we need somebody to prepare the sperm, but that is not mandatory in level 1. And however, if you have to employ one, that is an extra cost. But what they want is that the semen wash because it is going to be done in the premises of the clinic, it should be done by the gynecologist. So this is added work for the gynecologist, and she has to be trained in this in order to be able to do a good semen wash. Again, the path labs for reports have to be relied. We all know that there is a lot of discrepancy in the path labs that are generally reporting semen, and the IVF labs that are reporting the semen analysis. You have to be wary of that and consider that also as one thing when your IUI fails. So these are the things which are actually deterring gynecologists from now registering as level 1. So the takeaway points for performing IUI for gynecologist is registration, entire procedure to be done under one roof, good semen analysis, avoid delays, appropriate documentation and consent, and monitoring of results and early referral to advanced clinics if needed, and monthly reporting to authorities. So now let us take some cases, what could happen when you're trying to do certain things, or basically starting from IUI to IVF. As level 1, you get a patient who needs a donor IUI, and the couple is insisting that his brother will be a donor. How do you proceed? Do you outright reject, or can you do it? What does the law say? And can you freeze the sample in your clinic? What is the consent required for donor IUI to be maintained by the clinic? So all this you need to understand and know if you're wanting to do it. The donor sperm, even though it is a known donor, has to be obtained from an ART bank. You cannot keep any donor sample or sperm sample in your clinic. So screening, collection, and storage of semen is only to be done by the bank. The bank will obtain semen from males between 21 to 55 and examine the donors for such diseases. Mainly, they are the infectious diseases. The panel is given in the ART law. You have to get all those tests done. A bank shall not supply the sperm of a single donor to more than one commissioning couple. Underline, every time you have to be careful of the Aadhaar card, also of the donor sample that you're getting, because you have to be very careful that the same semen donor is not being supplied to all your patients. So therefore, Aadhaar card has to be seen, and of course, you have to go according to the law. So this is the form for the donor's semen sperm. I showed you the form for donor for self sperm and IUI, and this is the one for donor. So here you can see, and you have to endorse this. So therefore, you have to understand that you are complying with the law and not breaking the law in any way. Please see that all the all the indications and all the factors that are required by the law are fulfilled. Now you have another scene wherein the gynecologist has been treating several patients for infertility for many years. Now the gynae realizes that she has to register as level 1 if she has to continue her basic practice of ART like IUI in a clinic. Unfortunately, her workload is not much, and although she has a substantial number of infertility patients, but she does only 4 to 5 IUIs in a month. Now, should she register as a level 1 doctor, or should she just refer the patients to another level 1 or a level 2 clinic? That is what is bothering her. Should she do it or should she not? So no person can definitely, we have said that we have to be registered, otherwise we can't practice. And this has to be registered within a period of 60 days. Then you wait for the registration to happen. Only then you can start practicing IUI. So then she has to register in order to do an IUI, even if it is for 4 or 5. If she is not willing, then she should either send it to her friend who is doing an IUI and is registered, or refer to a level 2 clinic. Now, here is the same gynae who she has a very busy practice. So she's stimulating patients both for IUI and IVF and taking them to a friend's IVF center to perform the procedures, which is very, very common. But she does not have the required prerequisite for qualifying as a level 2 doctor. And she has not registered also as a level 1 doctor. So therefore, her patients are being sent to a neighborhood ultrasonologist for monitoring and a path lab for semen preparation. Now, can she continue her practice as such? Can she do ovulation induction and ovarian stimulation and refer only for IUI and IVF? Can she administer gonadotrophins in the clinic? So these are very, very important questions which every gynecologist is so angry about. I can administer, I know the protocols. Why can't I stimulate the patient and send them to the other clinic? Why should I be denied this? So here is what happens. you have to be registered as a level 1 for IUI procedures. Since she does not have the prerequisite qualifications for a gynecologist of level 2, she will have to stop doing IVFs altogether. So whether she likes it or not, she should not be doing it because she is not qualified and she cannot register as level 2. So now eventually what happens is she eventually decides to register as a level 1 ART doctor, but still wants to remain involved with the patients who need IVF. Now, is she allowed to stimulate for IVF? That is the question which has been bothering her. So here are two RTIs which were actually sent by a doctor from Chennai, from your city, and he has very candidly asked the same question: can level 1 clinics do ovarian stimulation for IVF and do the IVF at level 2 clinic? The reply is that any patient, any doctor who is actually doing qualified only for level 1 cannot stimulate for a IVF. So basically what the government wants, or what the ministry wants, is that anyone who has been given a certificate for a certain thing must do only that, cannot be subjecting the patient to something that he cannot do. So if the endpoint or the intention is to do an IVF, and level 1 cannot stimulate the patient. And if the intention is only to do an IUI, she can do the stimulation with the same gonadotropins and the same dose if required for her patient. So remember, this is the difference between level 1 and level 2. You can stimulate only for IUI in level 1. And how legal is it to restrict administration of ovarian stimulation drugs, gonadotropins, in level 1 clinic when it is already administered in any clinic or at home all over the world? This was the second RTI that he put in. And can a female patient who is undergoing IVF in level 2 take injections at any place of her choice, or should it only be in a level 2 clinic? So these were the two pertinent questions again asked by Dr. Arun. Again, the question is that because the idea is to restrict to IUI and IVF, so whatever is the intent, the patient has to be treated the same way. If she is allowed, you can give her gonadotropins for IUI, you can do it. However, to counteract this answer, we have the National Medical Board. You have the NMC, wherein the law says that anybody who is aware of the mode of action and the side effects of a drug can administer the drug wherever she is or he is. So for instance, if you have a radiologist, she can do an ultrasound and get the gonadotropins administered in her clinic, because she is aware of how the gonadotropins function and how the side effects can happen, if at all. So therefore, this question can be countered on the basis of another act, not the ART Act. Remember this. So we will find this discrepancy in the act at many places, and I will tell you how we can counter this safely, because we are still within an act, not maybe the ART Act, but another act. So remember this. And then therefore, what solution does she find? She cannot stimulate. So she sends the patients to her friend at an IVF clinic, level 2, on day 2 of the cycle to register first after doing the required investigations. Her friend sets the protocol and sends the patient back to her for gonadotropin administration and monitoring, which she is allowed to do. So she just keeps in touch with the patient. She does this. So is this the right way? Yes, it is the right way. She can do this. So remember, when you have a patient for IVF and you're a level 1, or you're not even a level 1, you just are wanting to refer a patient for IVF, you can definitely administer and even monitor. If your PNDT is already registered, you can do the ultrasound monitoring at your clinic, and you can give the gonadotropins, provided that all that has been prescribed by a level 2 clinician. So a 34-year-old single woman wants to plan a pregnancy, but has a live-in relationship with a man for the past 10 years. The man is not divorced. Now she wants to know her options. Can she be treated as per the law? What are her options for treatment? And as she has a known donor, would using his sperm be possible? Now here you look at this case. 34-year-old single woman, yes, she is allowed to have a pregnancy as per the law. Live-in relationship with a man for the past 10 years, she's not allowed. More so because this man is not divorced. No, she's not allowed to do this. So what she wants to know her options. So she cannot be treated by the law as per the law. What are her options? And this, she cannot use this known donor also because he is basically not divorced. So yes, single women are allowed ART treatment as per the law. However, this particular case, no, as it is a live-in relationship and partner is not divorced. What are her options then? She can easily do social egg freezing. She can freeze her eggs and they can be used later once, if she wants to go ahead with the same man. Once he's divorced, she can get his embryo made, get the embryos made, and then even as a single woman, she can have a pregnancy. But if they are married, then it becomes absolutely illegal. Even with a single woman, if he is divorced, then she can go ahead. So therefore, non-altruistic donor is allowed as per the law, but the other criteria should also be fulfilled. So again, a fertility center has got a license of level 2 clinic. What are the requisites for performing a self cycle? So here are the mandatory requirements. Female should be between 21 to 50, male between 21 to 55. I'm sure you must be knowing this by heart, but if you don't, please remember this. They should be legally married or a single woman. Marriage proof is not mandatory, but some centers like ours are opting for it just to be safe. Single man or same-sex couples are not allowed. Proper consents, data entry, everything has to be done. Most importantly, storage and gametes and embryos for not more than 10 years. Also, this data entry and consents have to be kept at least for 5 years, according to the PNDT Act, but according to the ART Act for 10 years. We shall come to surrogacy very soon. Fertility Center has got a level 2 license. What are the prerequisites for performing a donor? Now look at this. It is quite busy, this slide, because there are so many factors that you have to consider. The age of the recipient, we have already seen. Age of the donor, remember, female 23 to 35 and male 21 to 55. Again, married or single woman. One donor per couple once in a lifetime. Can be known or unknown. Must be routed through the ART bank. Donor embryo. The Act is silent on this, but since both gametes can be donor, it is legally presumed that this is permitted. So donating an embryo from another couple. So suppose one couple wants to donate an embryo to his friend or her friend, that is not allowed. That is not permitted at all. So a fresh embryo has to be formed. Insurance covering the complications of OPO, an affidavit must be signed by an executive magistrate or a notary. This is especially for the female donors because they have to take anesthesia. This is not for the semen sample because there are no life risks in that. Proper consents, again and again, proper consents and data entry, both by the clinic and bank. Storage of excess gametes and direct compensation is not to be given to the donors also. So again, be a word of caution for foreign patients. Foreign passport holders must come on a medical visa. No IRT procedure can be carried out on a tourist visa. However, the NRIs and OCI card holders do not require a medical visa. Now, what is the role of a ART bank, and what information will you be sending to the bank, and what documents do you require from the bank? That is also very, very important. So if you just go over this, the ART bank is responsible for screening, collection, and registration of the semen donor. However, for the oocyte donor, they are only performing a screening and registration. Oocyte collection and storage happens in the ART clinics, not in the bank. And of course, the banks can operate as both semen banks and oocyte banks. Reports maintain the donor records, and data have to be regularly updated in the National Registry, which is provided in section 23, 27, and 28. But sad to say, this National Registry has not yet formed. So therefore, we are where we were. If you have got a level 2 clinic license, can you also practice surrogacy? No, because there is separate registration for a surrogate clinic. Once you are registered as a level 2 clinic, you apply for a surrogacy clinic license also with another fee of 2 lakhs. First, you have paid 2 lakhs for level 2, then another 2 lakhs for surrogacy. This has to be renewed every 3 years. That was for 5 years. This is every 3 years. And the punishment is more severe. It is a fine always of 5 lakhs and an imprisonment always of 10 years or more. So remember, surrogacy is a difficult entity. You have to be very, very careful when you're performing that. These are some of the requirements for surrogacy. I don't have to go over all of them, but basically just remember that there we were talking of a single woman. Here we are talking of a woman who can either be a widow or a divorced woman of 35 to 45 years of age. Again, single man is not allowed surrogacy. So then a lot of certification is required in order to do a surrogacy cycle. And of course, the surrogacy has to be between the age of 25 to 35 only, not beyond that. Now, one of the sad procedures also that we do conduct sometimes is that there is if you have a young boy who has frozen his sample in your clinic prior to the start of chemotherapy for cancer, he did not survive for cancer. Now the parents want to use the sperm for pregnancy. What is the legal position on this? Can they take it and can they use it? Yes, very recently there has been a case which happened in Delhi, wherein this was allowed by the Delhi High Court on the basis that the parents can take the sample of the boy and take a surrogate and a donor and make a baby out of it so that they can have a progeny of their son. So this is now allowed under the law. So again, this is the form that you have to fill for that. Remember that the minor's form has to have an undertaking of the parents or the legal guardian. However, for the majors, there is a form which is separate, which tells you that the wife should be signing also about it. And the man who is actually the actual patient, if he dies, he should have signed before his death as to where the gametes should be going. His consent for posthumous use of gametes has to be taken before the death of the patient. So that is the difference. Here it is the parents and here it is they themselves. And the first priority is that of the wife. So again, another vexing problem. A couple approaches a clinic for genetic testing. They have a strong family history of autism. They do not have a child. Is PGT indicated? If yes, which one? If no, then why not? If autism is caused by a genetic disease like Fragile X syndrome, it can be done. And what are then the indications of PGT in the Act? You know that these are the three forms of PGT. In this case, because it is autism, then PGT-M, where you are looking for single gene defects, could be done for fMRI gene. And this is done followed by a PGTA for any aneuploidy. So the embryo may not have the fMRI gene, but it may still be abnormal. So first screening is PGT-M and then a PGTA. So therefore, you have to do a double testing in these patients, but it is definitely allowed. Now, another exciting thing is a savior sibling. Now, the first one was through Dr. Manish Banker when he was at Nova. This is basically a donor baby, or is a child who is conceived in order to provide stem cell transplant to a sibling that is affected by a fatal disease. So you do a pre-implantation genetic diagnosis after making the embryos, and then you do an HLA match for the existing sibling who is born, who requires a transplant. You do it with the baby who is born. The umbilical cord blood of that baby is taken, and once there is a cross match which is there, then we can easily go and do the stem cell transplant into such children. So we have done many successful cases after this first one, majorly for thalassemias, also for sickle cell anemia and osteogenic imperfecta. The most important thing that we all are not aware of is the pre-implantation genetic testing is also allowed according to the PCP&DT Act. And these are the indication. Now let me go to the next slide. What if the disease is sex-linked? Are we allowed? Can we do a PGTA? ART Act is silent on this. However, the PCP&DT Act definitely permits us to do sex-linked disease PGTA for chromosomal abnormalities, genetic metabolic diseases, sex-linked genetic diseases, hemoglobinopathy. So remember, you have to just inform your PCP&DT Act area, the officer, and then you can go ahead and do this PGTA also, wherein you have to know what is the sex of the child. So then finally, we come to what we were starting with, level 1, level 2, ART bank, and nothing. So when you are level 1, you will do only IUI. When you are level 2, you can do everything. ART bank stores sperm and oocyte donor. And then if you have none of these, you associate either with a level 1 or a level 2. So what are the challenges then? So we are not aware of all these things in the Act. We are probably doing IUIs without ART level 1 registration, and some of us are practicing IVF without the required certification also. So what are the new standards? It says you must register you must refer to level 2, attach to level 2, or if you don't want to do anything, just stop doing IUI and IVF. Together, we can therefore provide the best services to our patients. All poor practices must stop. And now, to understand where we are today in 2025, the boards are formed. Ongoing registrations of clinics, ART banks, and surrogacy clinics are going on. The national registry, as I said, is non-existent. Court cases are pending because of ambiguities. Level 1 doctors are not registering, hence there is no control over IUIs. Both female and male donors are becoming scarce because it is one donor, one recipient. Gametes and embryos can be transferred from one place to another, but with the permission of the national board, and it takes time. Many times when there are national holidays, they just sit over it. Then surrogacy is even more tedious and expensive. It is altruistic, so it is very difficult to find altruistic surrogates. So look at the board today. How many of us have registered? 6,726 applied. Out of this, only 22,044 got registered, and there was 159 which were rejected, but this doesn't complete the 6,726 where the applications are still pending. So also, if you look at the surrogacy clinic, only 30 surrogacy clinics across the country are registered. This data is from the website on which I drew out on the 9th of this month. So just 2 days back, this is what it was telling me. Similarly, the ART bank is so scarce, you have only 75 registered, 593 registered banks, and 75 have been registered. But again, this doesn't complete this number. So you remember that there are so many illegal players which are actually functioning in the country. Beware and be careful of what you're doing. So let us review our SWOT analysis again. Minimal opportunities are coming our way. We are not consolidating our practices. We don't have many numbers. We are all doing singular practices. There is hardly any research and scientific advancement. There is, of course, a lot of weakness, ambiguity, implementation is poor. The act definitely is not doctor and patient friendly. The threat is genuinely coming up. Strict data management, severe punishment, third-party reproduction is difficult. And of course, it is unavailable to those who really need it. So then what about the strengths? Lastly, partly effective. Some amount of regulation has started. Weeding out of illegal players is hardly happening. I hope we will stop the unscientific and antisocial practices, but we do hope for a better governance. So that is where we are today, and we are navigating through all this kind of a slush. So let's hope that we win and do better ART practice. How can we help guide each other for registration, consolidate our practices? Many level 1 clinics can make it cost effective. Join hands with level 2 to refer patients for work, or you can work with them. If you yourself qualify as level 2 but cannot start their own center, enroll with a level 2 registered center. You can take your patients there and do it yourself also. A word of caution, do not break the law. Do not break the law. This is difficult as the PNDT and MTP laws, and the punishment is very severe. So what should we do? We just flow with the water, comply with the rules. Do try not to be flexible to please a patient. Remember, many of us have got into problem with the PCPNDT Act on this fact because we say, chalo bachara, the patient is poor, usko help kar do. No, please don't do that because the law is very, very strict. And so if the doctor remembers ethical, moral, and legal practices while treating both couples and surrogates, there will be no conflict and there will be no punishment. I thank you very much for being patiently hearing this and being with me through this lecture. Thank you so much. Thank you.
Thank you, ma'am. What should I say? So much of points and so much of doubts clarified, and the way you just ran through your slides, not missing any single point. I wish all my postgraduates logged in today. Anyway, it is there in the YouTube. I'm so happy. I will ask them to see this. And
Thank
anyway,
you.
next time, ma'am, both Ashish sir and you will be given time to discuss again. And
We will
so
both take
nice.
1 hour each. 1 hour each for both
I
of
know,
us.
yes, madam, definitely. And so the age factor. And I have 2 questions for you, ma'am. One is there was a movie where the hero goes and donates semen, and it is used for multiple people.
72 times.
That is
72.
not allowed, no,
That
madam.
is not allowed
That
anymore.
is not allowed.
I
Yeah.
removed that slide. I removed that picture from this thing. I said, let us not talk about it. But yes, that was the Wiki donor was the picture, and
Yes, madam. Yes.
you
It
know
was
that is
Tamil, Hindi,
it's not
and
allowed anymore. It's not allowed.
Okay.
Yeah, yeah.
Ma'am, very good talk
Thank
and
you.
very informative. You have cleared so many doubts, and it was case-based presentation, ma'am. We are happy to listen to you, ma'am. And we don't know whether the patient is donated the semen. We don't know he may be donated to one city and again going to another city. So how can we know by taking the Aadhaar card?
Very, very
We don't
good.
know.
Very good. No, actually, you have to go to the Aadhaar card portal and check the Aadhaar card from there, not from what he is giving you. You go to the portal and check. If it is a different Aadhaar card, then, generally what they do, they all know this. All the ART banks know that they cannot donate more than once. So they keep on making fictitious Aadhaar cards for them. So he will come today with one Aadhaar card and then it will be another Aadhaar card. So you just have to go to the portal and check the Aadhaar card. If it is the same as what is being presented to you, then it is a genuine one. Otherwise, he's made it up. Then you reject the truth. Then you reject the sample.
One
Otherwise,
more thing.
we are supposed to have a registry for this. In fact, Madhya Pradesh is the only state that has a registry for donors, whether it is egg donor or sperm donor. They have a registry. So every time you do a third party, with a donor sample, then you have to register in the registry. And for 3 months, you're not. Earlier, it was 3 months you were not allowed to use the same donor, but now it is forever. Once the donor has donated, whether it is an egg donor or a sperm donor, that patient cannot donate in Madhya Pradesh. That is for their state. But none of the other state is following that as yet.
One more thing, ma'am. I'm taking my patient to the ART1 clinic for IUI. Should
Yeah.
I be registered there also
Yes.
if I'm doing myself
Yes, that's a
IUI?
very, very valid and very good question. Yes, you have to be registered there if you want to do the IUI yourself. However, if you want your friend to do the IUI and she has a registered clinic, she can do it for you. You don't have to register. But if you want to do it yourself, then you have to register.
So against the same fee, I will have to pay
No,
everything.
no, that is already paid. She just has to add your name to her
Oh.
clinic. That's all. The
And you have
clinic has to be registered, not the patient, not the doctor. The clinic has to be registered. Only the name of the doctor should be included in the clinic. That's it. So, for example, you take these big hospitals. Say, take your own Faridabad. You take Amrita, for example, and you have about 20 doctors in the gynae department. And they have an IVF unit. IVF unit is registered as level 1 and level 2. So out of those 20 doctors, 10 of them will be registered as IUI doctors over there, and they will go and do their sample. The sample will be made in that center, but they will go and do their IUIs over there. That is how it is done.
Ma'am, the path lab who are doing the IUI, they are doing the wash. Do they need to be registered?
The androtex, it is not mentioned in the law. It's not mentioned till now. Actually, they have not included the path labs also. They have not included, only the radiologists are included in the PCP and DT Act, but the path labs are not yet included over there. Therefore, we can say that they are not required, but sooner or later they will start doing that also. Once they get to IUI, they will start doing it.
Madam, what about the sex reassigned people, ma'am?
Sorry?
Sex reassigned.
I didn't get that question.
Ma'am,
Transgender people, ma'am.
Sorry?
Transgenders who
Yeah.
go for reassigning surgeries.
Yeah, so basically, the law says that same-sex couples are not allowed. Now, if you have a male, it's very difficult, but of course, he can donate his sperm and keep it as fertility preservation in the semen bank. A girl, or if they, like, I had a lesbian couple. Now they wanted to go through an IVF. They are not allowed because they are same-sex couples. So after 3 months, she comes back to me as a single mother. She says, "I'm not a lesbian. I want a baby, and I'm under the law. A single mother is allowed. So you can't refuse."
How do they believe? You can't believe it.
No, definitely you can't, because I already knew she has a female.
I know.
I already knew. But as far as the act is concerned and the legal part is concerned, she was right.
I'm single mother.
Yeah. So she bought her own donor and she had a baby. She has a baby. So that way, there are ambiguities in this law. That is why there are so many court cases.
Yes, ma'am.
Today I had a couple. The wife, she has a baby in our own IVF center. In 2012, she had. Now that baby has got a bicuspid valve problem. So now she wanted a sibling for that child. She is 50 years. Her husband is 55 years. According to the law, they are not allowed. But she has embryos with me, you know. So now we will have to take special permission from the national board to make her, do this, because it is for the sake of her child, for stem cell therapy for the child. So these situations happen, and then you have to bend a little backward and try to help them. That's all. But of course, you still have to remain within the law, like I said. Yeah.
Dr. Aburba, you want to add something?
Yeah, absolutely. First of all, thank you so much, Vijaya ma'am, for organizing such a wonderful webinar and to get two of the most inspiring speaker with us. Dr. Ashish sir himself is an encyclopedia, and Sonia ma'am, what to say about ma'am? And ma'am is a teacher for me and always learn a lot of things from ma'am. And today, really, ma'am, it's an eye opener. Absolutely, it's an eye opener webinar. And the your lectures is always, I always used to. I am a great fan of yours, and I always used to enjoy your lectures, ma'am.
So much.
Now, ma'am, there is a one question always in the mind of like I am from a very small place. So, like 2 tier or 3 tier cities, that a gynecologist is only doing like the induction and timely intercourse. Okay, so they are using gonadotropin also, and they have the PCPNDT, and they have the ultrasound. They by themselves is monitoring. So, are they have to registered under the ART law or not?
No. They are only
Okay.
doing induction ovulation and timed intercourse. They are not handling the sperm. They are not handling the sperm. So gamete handling is not there. So that is allowed, and they are registered under PCP and DT, which is fine. Only when they handle the sperm, they have to be registered.
Ma'am, suppose that like most of the nursing home or small hospital, they have their own path lab. And if the path lab is like detecting the semen test, if they are doing semen test analysis, so is they have to register under level 1 or not?
See, for semen testing again, that like I
Yes,
said,
ma'am.
path labs
Yeah.
have not been included in the act for semen testing.
Okay.
Path labs
Okay.
have not been included at all. So, but of course, sooner or later they will be. The more big difficult problem is that these path labs who are having, very scantily trained, skimpily trained technicians who have no experience of semen, their reports are very different from what we get. And what happens is that in these clinics, these people are doing IUIs after IUIs and not thinking that the cause is male factor infertility. They don't
Yeah,
realize it because the sample is not reported correctly. Madhupriya will agree.
correctly.
This is the common problem that we all are facing as IVF. Even you will agree that this is a common problem. And therefore,
Absolutely, ma'am.
when we do this testing and we tell them that, okay, it's your sperm which is at fault, he says, how can that be? Or especially small town, मेरा कैसे हो सकता है मेरा तो सब कुछ ठीक है इतने देर से मुझे किसी ने नहीं बताया आप कैसे बोल रहे हो so that antagonism comes in so that is a problem that we have to spread this knowledge to all of us that the semen analysis is a very important component of infertility and that has to be looked into very, very seriously. That is important, and it is rising. We all know that male infertility is also rising.
Ashish sir, your last word.
You didn't give me a chance to say that. That's unfair. I
Yes,
did not say the last
okay,
word
yes,
for
sir,
Ashish.
yes, sir, yes,
Okay.
sir.
After him.
After him, yeah. Ashish sir, please.
My last word will be Dr. Sonia Malik will say the last word.
Oh, yeah, very good. Very, very clever. So you are as witty as ever, Ashish. But I think my last word is that he has to sing 2 lines before we finish this webinar. He has to sing 2 lines before we finish this webinar.
Oh, okay.
You can sing on hypertension if you want to, but you have to sing. He's an excellent singer. If most
We didn't know that, ma'am.
yes,
Absolutely, yeah.
absolutely.
Ashish sir
He's
is
awesome. He's
Sir,
very,
please,
very good.
sir, please, let's close with a good song.
Two lines. He should.
Yes, sir.
Please. If it
कभी
was so
अलविदा ना कहना कभी अलविदा ना कहना चलते चलते मेरे ये गीत याद रखना, कभी अलविदा ना कहना,
Beautiful.
अलविदा ना कहना. Meaning, you arrange another webinar.
Never goodbye, never goodbye to all.
Excellent, excellent.
Thank
Thank
you.
you,
Sir, you
Ashish.
are
Such
awesome,
a
sir. Awesome,
such a
awesome.
So
warm,
nice.
such a wonderful
Thank you.
Yeah,
webinar.
let's
Thank you,
leave
Very
with
much.
good
But one
happiness.
thing I must say that each of these topics, like Sonia Madam, is an uh, par excellence, an orator
Yes.
par excellence, and she was so good in her approach. I mean, the approach, clinical approach to the problem, I enjoyed it thoroughly. You know, every time I listened to her, I invited her, especially cordially for our AICG. I was the scientific chair. I know her, so. But she's really a gem of an orator. I'm sure that the star, this thing, lecture of today is the Sonia Madam's lecture.
How can you say that? I didn't say the last words.
Both the different topics. Actually, I
I
should
have learned so
congratulate
much. I didn't know
the
such a
Madhu
lot.
madam. Selection is Madhu.
Yes,
Ashish
absolutely.
sir selection. Because I don't know much about IVF in infertility. I told somebody who tells the practical points. I don't want the typical lecture. She said she is the correct person.
But
Thank you,
your
ma'am.
teaching passion, Madam Dr. Vijaya, is excellent. She's
Yes.
traveling all the way from Chennai to Karnataka, you know, for giving a lecture in my program. So that's great. I appreciate that very well. And she's so
Thank
humble, so down to earth. And whenever she approaches anyone for any scientific program, her approach is so modest, so benign, and so, you know, involving. I mean, very cordial. So I couldn't say no to her. I said, don't travel so much. I'll
Thank
come
you,
to
sir.
your
Thank
city and then do the program. But she said, no, I will go. So that shows the greatness of a teacher. I think she is extremely popular in her student cycle, isn't it? If I am not wrong, then she must be. She must be the very popular teacher, HOD.
Yes, of course, of course.
Thank you, sir.
Of
So
course.
it's
Thank you
really a
all.
pleasure interacting with all of you.
Yes,
And
sir.
really, really, life is a journey, but we come across so many pleasant things in life. Then I'm really, really, very, very much thrilled to participate in this
We keep
program.
getting irritated by seeing so many
Thank you.
webinar flyers on the WhatsApp groups.
Thank you,
But then when
everyone.
we
Thank you,
attend
everyone, for
these
staying
webinars,
till 10 o'clock. I'm so happy. Madhu, can you give the vote of thanks, Madhu, please?
thank you so much.
Sure, ma'am. Before we wind up, there are 3 questions that will be answered by ma'am, and we will send it across to the doctors. Thank
Okay.
you so much for asking those questions. And for all of them who have been here till it is going to strike 10. So we've come overboard for an hour, but still we have been having so packed webinar. Thank you so much for both the speakers who have kept them roped in. Thank you very much, madam. Thank you so much for accepting. I know how busy you are, how much you've been running around. Sonia, ma'am, thank you very much for accepting to come to the webinar.
Thank you.
Very, very happy to have you here, ma'am.
Thank
And
you to my
sir,
chairpersons. Thank you to Vijaya. Thank you to you. Thank you to everyone. Ashish,
thank
of
you,
course.
ma'am.
Ashish,
I'll
of course.
personally thank Apurva because I didn't know that he's such a strong winner. He has
Oh,
won so
yes.
many things that
Yes.
why there is a long list.
Sir, it's all
जय
due to
फॉक्सी का जय
blessings
में
from the
ये तो
seniors
फॉक्सी
like
का
you.
जय में
All the best, ma'am. All
Thank
the
you so much,
best.
ma'am.
Thank you, Kiran.
Thank
Thank
you
you.
so
And
much.
thank you,
So
Professor, sir. Thank you
Good
so
night.
much for
Good
coming in
night.
Thank
and
you so much.
making it very
So
live.
I'll be the
Thank
All
you
the
blue
very
very
light
much,
best to
there.
each of
Vijaya,
you.
ma'am.
Alvida.
Thank you, Apurva.
Thank
Thank
Bye
you.
bye. Bye
Bye.
bye.
All the best.
Bye,
to all.
ma'am. Bye.
Thank you.
Bye,
Good
bye,
night,
Sonia,
everyone.
ma'am. Bye,
Bye.
Ashish, sir.
Bye.
Good night. Good night, everyone.
Bye, bye.